You are facing a patient. The patient will present choices. So, 90 days after bleeding, I would do the same as a variation, as you can see, basilar division is bled. It's a tiny bled. The web, this with all we have, there is no other patient. 1 year ago, because round balloon of the catheter because more. Having this would having this due to the aneurysm years ago, we would do the same. The neck and to fill the aneurysm, the masturbation is to raise. Having this with this operation, bled, maybe you can put it later on. The best way to do it, extending that you have of the patency of the piece to the PCA. The best the protection coming and going towards the place the below the neck and side here, which is again same inclusivity, put the web inside. You can decide to having this to handle this case. There is no real way to do it. You do high operation, you constellar, then you put back, and then you get this result. And you can clearly level, it's still visible, and there is not too much things to do. The tremendous number of patients with coils and it was performed on aneurysm and then aneurysm. This is if you compare different study aneurysm, including coil, it's good. Keep on. That's a question. Simple choice when there is no other reason. I mean, you can see them that present in emergency. Now we can see water. I don't think it's not too much. You just what? You get immediate. And it's a very intelligent, clever, and not difficult way to treat this. Nothing. You have this not tolerate. Bypass no piece of cake. Struck the parent artery in water. What was done? The flow diverted as you can. So and cannot tolerate the parent vessel occlusion. You think about this. So it's a rather case. In this situation, you do vessels. Now reconstruct the flow down, the big deal. It looks, it is simple result on the long term. So those years ago, technically simple, stormy, it is all life. You have 50 head can is clear that she got a bleed. She got a bleed. She got which strategy to and having this involving the more, including superior cerebellar, having a P which is giving writers? How is taking risk? I mean, who knows? Nobody knows. It's not a big thinking. There is nothing. The case to the material we have. Is it reasonable to stand? No. It is reasonable. Specific is presenting in a looking, but it is. Day one after treatment, presenting with the this we took. We demo look at the vasocele. It's very clear and artery, and this is the of the origin of. Did else could this patient, but this, why is this patient presenting? Is this patient then why after we check is the spiritual view intend what the treatment will not to will have clot in the cerebral artery aspect of clot. The patient still has. Let's have a look at lows. 5 months is gone, which is gives rise to artery here. She is clinically intact. Yes, we did in a specific environment because of we maybe in fact this for the best compared to what it is. Let's have a look at this case. Offer this flow occlusion. It's not. Do again, we drug the vessel. As far, nobody knows what's going to happen to this. So we flow diversion, what's happening there. Let's have a look at usually after treatment modification of the option. We are not anymore. And the second thing, this is and this big portion which is nothing except restented diverter. This 14 months after retreatment, 20 months after it's gone, which is this vessel. She still has this. Is a what result? But when we be the result of your job in the special in this treatment, we be the future, and we have to admit it. This is what. That's the worst for small aneurysm. We have to look at the result. The nicest. No, it doesn't make sense. The patient, the best. Let's have a look. In 19, the balloon, this is immediate control angiogram with dye around February, October. There is a base of the aneurysm left. It's gone. And let's go. No modification. 5, same. It's reasonable to. Fortunately not. We have to admit something different than you and I. So the best result is not. Okay. Let's have a look at this tiny little supraclinoid aneurysm. Put a stent. Because maybe because does it make sense? No. Because I have the surround. Because I'm the best lover. That's it. Maybe because I want to line, white line and the blue line. Resistant to potential risk to put a no. You have this small acorn. You put a small balloon to protect. No. Did we put exactly the stent? We can put a stent in the complex? No. The direction. Do we increase potential healing? Yes. The patient. No. Critical because of the pedal. You. I truth. Let's have a. We put a balloon. Coils. Why did we? understanding that this is what the stent looks after the narrow kinking of the stent, as usual, clearly everybody knows, everybody has. In my how depends on others. This patient understanding that this stent is completely blocking again to the aneurysm. It's useful for the patient. Definitely. This is another case with balloon. Why? It's not necessary. And the best long-term follow-up, but doing a Y stenting is the stenting versus the coiling with something left at the neck to move for most stenting. It is stupid. Nice to the screen. It's nice to stenting. The patient wants to get the issue. In wide neck, possible to you just take that you place the pin, it doesn't occur. You can found, but the round balloon protects the coils that you pack to exist. You get this wonderful result. Nobody anymore. Patient now, at see here, two balloons in a Y configuration in the middle, nothing is in the side. You do again a Y stenting. Why not leaving a vessel? Because we want, and the best cosmetic basis is how do we balance the risk of the. This is the result. How do you treat? You put a Y stenting. You see the Y stenting in the middle. The patient 7 months is. This is the vasosity here. Tight kink and this aneurysm could coiling protection of the neck. This, doing this Y. No more the problem. Now this guy. Now we have a better tool. We have this braided stent to the vessel. Look of the. This is an angiogram. Not difficult to with braided sick put because it's a very tight easily to what you can get with. Coil in the middle usually is the very good. After treatment, not that easy. This new the Y stenting with the braided. Here again, this patient baby in a Y. In this case, not that. Why comfortable? But I'm not sure why that. A very clear band, what it stays the same. Nicely to the wall of the best protection. Stainless steel, which is thinking or done to that. It's difficult to stand about that. A negative. How do we balance? They know. So, why critical point of view it conformed? Probably. Why do we to put those Y stand to bifurcation? This 4-year-old female want to do the treat, thinking that let's do the treat. If she goes somewhere, I am right. This is the pipeline. You don't see it. And after the treatment, not too much aneurysm here. Angiogram. Here in branch. This is not the branch. This is the. I am confused. Stenting. Are we scientific proves that one is the T? So you have it's best for the patient. So we treat change the antiplatelet. Clot. You clearly see the core much longitudinal. 2 years follow-up. almost normal. But if you look at the aneurysm is gone, but you bet deficit, she got a bet, I don't 2 years, patient, this is the aneurysm. This short peak discovered this aneurysm, and I didn't want to treat this aneurysm. But a bleed, don't want to know that. So we did a very simple, just the liver. This is what's done. 5 hours after the patient is left any part here, the shallow pacification phases of the angina, the cover, the MR of the patient, and let's have a look at the 3-6 months. Our annual vessel is very, very, but definitely, but the patient has a deficit. It's the right decision to do that. The result published in the literature from a 2-year present in treated with flow diverter, 6% vitality of 0. How do you flow diverter? You don't have the choice. Yes, and flow diverter. One. Of all what in 15 in fusion group application with the P. You have sick complication in 2.3, non-stent group 3.0, related mortality as the most significant in look at what's happening in occurrences. 5 improving to put numbers. The stent cost to use a stent when should we be using distribution? Have a look at 1%, 5.6. It's efficient. Stent and flow. The more is and balloon, initially, you got the result, so keep that in mind. Where's the candle again? No. The change in chances, a percent as fused to deal with. For the which is more than those aneurysms are different too. Complication of the whole in this course. Again, should what makes complex wide neck by divide. How are we going to test? How to do so much time useful? This is type of how can bifurcation use this pick the best way? Web. There is a lot of probably done with web result. Final attempt, different stones follow. But what is the 12 months? When you look at the, what do you notice? That the discussion there is happening. Big push, so different constraint, and the retract, it's 50% results so poor. All kind of aneurysm. Do any tool, we use it. It's exactly because you have a brush depending on how involved. But the selection for the but for the tool now endovascular increase every day. Every day too easy not to have one with equalization. This is not equal.
Very much presentation. Comments.
So, what is the use for improve
honestly, I don't. Training, your personal skill. You look at this using your hand, all what we do, what we have been doing, a short period of time, give a good average, you can offer % of good, the 10%, when you do it, understand, and then at the very, the result, take a death you have is not the complication. The management of the complication, having the technique is not that difficult. That's another song. It depends on your training to manage mental stability. When you have a for a few seconds and start thinking, so you can avoid. Oh, it's an answer which is not.
If not, Sir Moret.
Is from have a big experience. Flow veterans, please.
Luis, and this number is a big number. I think this is a very have else experience and things we still do not know, which is related to a pipe. Others surpass P64. The same significant differences in their efficacy and in their. I will focus on the two pipelines of the same, and the device is released from the wire and the product main. Back to Professor Murray was phenol. So this is our and made and we started which from the in April 2000 and the sacral aneurysm we clipping aneurysm with flow pipeline as far as the medication to really get a little more than per year was to had displacement in the sac of a large. This was exactly the trigger point to come up with a new development. Was the crane had used in the very beginning thrombosis related to compliance. Follow each pipeline and this you can. This is the first at 50% of the leak after 73 sacral aneurysms to treat that stand or flow diverted. Simple the CTs coiled manipulation July effect and non-bifurcation situation significant after coil occlusion is in parathermic aneurysm. You see, okay, we expected to have vasos currents. Again, it's fortunately with this rupture, a result is what you see here, the to inside and to straighten the vessel into the month later artery. The interior so use it in the posterior circulation. The reason today is done with this device. If you use it related to the patients and of need large micro. If you try to that device was deployment. Salutation is still used. Example for a failed. Why I personally lady had a terrible, not nice, no stable position. Admitted. Again, the same. The artery is immediately occluded. No damage. Simple vasospasm. Flow diverter. Plenty of other aneurysms in the background. Device. It happens as I said. It was always related to the aneurysm. This is after the careful longer covering. I mean, you can landing zone aneurysm and have a good result. So they and 50% solution with significant increase to minor remnant. MC, if an artery is originating from the artery, and you see remnants in aneurysms that treatment, no other side, and this significant lady within the toe, and this is the second. This is the aneurysm between the arteries, and this is the aneurysm. So I had normal typical situation. Pair of them result. These are in properly aneurysm complicating a bifurcation situation. Delayed obliteration in the aspirin 70 pressed in his 2013. The of course still 24 go down the aspirin to 50 milligrams instead of June year now under. One of the factors that may be react in endoplavics. We had no sub. The reason I saw showed including in vitro and in vivo. It's true for most unavoidably have a shot. It is flushed and deployed. For the P6 without deployment, fully you can remove all of air and related micro creatures. Four sides of them were simple, mostly with pulmonary. And we told steroids, but he continued committed suicide. Infrequent parathermic aneurysm is a cross flow, which is flow to move a superior cerebellar aneurysm. Version and this was stuff. This is hyperplasia, behind ischemia, other aneurysms, and decided that he wants to go for the MC aneurysm, supposed to be on so which can be withdrawn and the frequent and it's device. Aneurysm have a variety of reasons. Intimal hyperplasia is that's the issues.
23 intimal hyperplasia. You find after placement
of intimal hyperplasia quit, or if they're a smoker and they want to continue, then go. The case we had seen with had severe with smoking.
you are hyperplasia so with another flow diverter. I think is different.
Frequency of intimal.
And ever see in France?
Sorry?
Producing in France and in my
Visit you?
the company. So it's a new deal, and why don't we?
No.
So you're like Apple.
No, for sure is that I think we did an aneurysm with
64 in my. Yes.
It's easy. I mean, I sent to Christophe.
I don't complain.
Christophe Letac app.
Okay.
Surpass from okay. Dr. Kim. Okay.
More longer.
Simple answer. I thought diverter depends if you. So we clearly know. So when they are to deliver the best, but please, it's theory and.
Dr. Professor Luz of Pipeline from
Okay. To come and talk about the rational another, and this, I think it is, and Murray, whatever we're using, we need to kind of approach it. We have a clear vision of what is the goal of your therapy. Circulatory, that's in goes to clip an aneurysm, but we need to, and also peculiarities that come with instinct, and they do basically the tools that we're using. Expect of a tool. The operator has a risk to use a tool, or might have to understand might be useful. Benefit ratio. There's some things that we. So we've been doing when the team sort of the aneurysm, the coil, the sac of the end, thrombus coil calls us, and that's how we know that it does very nice data, metal coils and metal coils, significant. And so we've been coiling to us to pipeline, coiled quite completely, less after 2 optic chiasm is see about remnant as if it's. Talk about a number of things. Size, a truly understanding of. So let's ideally we want to close. Device is critical. The animal that was done, it more or less guarantees a specific tool stays open. You can see for closing an patents the stay open, which the branch vessel closes, is our effect. There's a safe, but so just in a cartoon sense, understanding of how these devices, the device idea, there's slowed flow circulation with the thrombosis is enough of a decimal overgrowth, and we know this from also that if the flow, some of that delayed fashion, impairment, satisfied porosity could be used. And it's still down to hemodynamic, more importantly, hemodynamic comes to the thrombosis required for Q. You have intimal of a normal segment. This was did in puffs, a very just this, but look, also is compressed. The aneurysm, not just the in place. It's not just effect is gone, but normal device in energy of the, and so you fill the vessel and happen all the time. No, ultimately we want. The literature has become. I'm not coaching. Very good friends of mine. Make it personal, but let's be honest. Single pipeline occlusion rates, complications. What they're doing is they're treatments. There's no between age and size of aneurysm. Of course, those are more. This is what's really corrupting assessments that's going on. Came to our attention. The woman comes back at 6 months. Problem. Look at the MR. Aneurysm, then going over to the other aneurysm. You can still be clinically active. And this the endoluminal construct aneurysm. So let's look at these abraded stents in AJNR. When you size a device, this of diameter, the cell of the diameter of the device and a density. Subnominal higher porosity, and it's vastly oversized presentation of velocity and parabolic cell structure about what device that you're selecting. In desirable vessel, you can get over deployed within a 3 millimeter vessel. It distal to the end, and so you increase the coverage of his exit of devices. Furthermore, you get a exiting and reverse endoleak ultimately. So how can further dynamically, if the flow zone of your aneurysm, the exit at the outflow property inflow, how can we do a little better and try to get a device that's matched to the aneurysm of the vessel. It's in parophthalmic and cavernous segment and create proximal and distal and you can shift your trend as to your overlapping devices that you've chopped up overgrowth down the road. This is also where we use them. And this outcome, but because what you're really aneurysm to go. Now, much more complex to curvatures, and it's describing it like I have drawn in the devices lapped periodic zones of clinical segment aneurysm. The something is that that these recently, which is more or less the observations in these two. Where are we going beyond? We knew actually, this is a case, a small bystander arresting. It addressed both unusual neck configuration, I believe, and it would, or with the low porosity. You'd still have, I think, some, with a device selected NYU transphenoidal for a large aneurysms. In the past, there were, some actually take the, try to overlap a few neuroforms. I actually had quite, Demetrius was going to talk aneurysm or these very nicely addressed at the vessel. This was, it wasn't initially presented, kept there for a while as the hemorrhage came to us. We were thinking elected to coil, get a very nice reconstruction of this with coils, 6 months of aneurysm. It was a form in this particular case. Testing into the upper division, 2 overlapping pipes, the 9-month resolution of the aneurysm into both MCA. Periculosis, the picture broad-based, a little there. The wise backed out, treated it, so they can be done related to the treatment devices. So you have to get everything. It needs a shunt. You very methodical approach 3 months. This was the one slightly when you see that there's been callosal artery. Follow-up angio. So here's another 4, and this is. What about complex case? Differentially involved coming off of the sac of the vessel to us angiographically. Now you have to, if we built the stent sufficient enough that it goes over her and so later to, and you see there are with the we were able to puff its chain is filled from the articulate with essentially to where you can musculature. The posterior circulation, treating one of the first patients, it was a young girl construct result, looking at the cross effect over essentially dissipated. A lot of people were excited. Where we really the anatomic features of that the aneurysm of the basilar is really situated and the superior cerebral sac of the aneurysm of its growth in that aneurysm collateral. Of this case, it was other groups publishing. Groups are doing of cases. You have to understand all of the anatomic features, and so some treated remodeling. So here's one much bigger than this. You can see it's this. So you can see that the mapping away. And there's another a VB junction. There's nothing here in to keep the vessel alive. Someone had tried to it's mostly addressed and addressed will be a different kind of case. We put a construct, a device in a month later. We have headaches, scan, and you see there's runaway. The shunt first, stage of the therapy. You put the has grown exacerbated, going to lead to cephalus picture from, and this is improve it. Number of more complex that we have to put the shunt in, trapping the aqueduct of can go about treating it, but the aneurysm, and so really is improving. But it's not just here in Florida that has a south. He improves, septic and die. You have to have. There's an maybe he has a better forever. There's going to be other issues. And rationally use benefit horrendous taking that risk. At other times, no. This maybe that we treated had a fabulous result. 6 months off like every okay, back later. Vessel. So constructs are going to take a long time that can grow across time. Utilized anti need to be extended. Our cookbook says it's all of these things, and what. So in when I was in a rural area, an experiment. Really have an. I'm going to open up. Our house up against a tree, long time ago, a couple of years. The camera is basically at my, so I'm looking up. the inert has been increased 2 meters, 3 meters, yes. And so are taking advantage. And so it's the beginning. There'll be new. It's the beginning of what automatically. Thank you.
And then question. Dr. Chris.
Thank you for the invitation, Luis, to surpass flow diverter. It's going to be, and I will show the diverter, which is 2012. The surpass self-expandable, the other flow diverter catheter. See nicely here on the sim. An outer diverter. The flow diverter is delivered by the it's in length between 12 meters up to 50 form aneurysm. We have biology of this layer of catheter advantage when compared to flow that guide wire facility. If you have a balloon, the act quite important is that shooters with shuttle sheath as flow divers as well. Be like the trend the catheter, the flow diver in a case example, we will cover a length of 60. The neck was rather large to avoid the additional coils. The included the vertebral artery. The center study Europe and altogether 100 include located in the success rate cases positioned but completely covered flow divert inclusion and inclusion after inclusion here. That in you open months in the most center and flow completely covered first broken patients and a procedure in 4 patients serpent patients I've all inches flow diverters available and aneurysm system. So I used aneurysm located AC geographically and position of the position precisely as you can the just a recurrent artery of how second case of and this patient and sac with the guide wire to dive from here in so only flexible of any propping the system into around the flow of the flow diverter of the flow diverter for the engine control are done for head. Partially the CT shows that there's occasion and they were reluctant because of the calcium and put coils in position past flow diverter coiling and the put in the delivery, and this is flow diverter in order to surpass. And you see here the outline to this angiographic flow, which was perfectly fine. This patient again did very well. Angiographic control in the mean reduction of flow diverter clinic and play any biological system along the flow increase osmosis. The first is which can and the as the was a better flow diverter now in, so been done to the and even the second streamline flow So we've gone this allowed up to 8 flow diverter lengths. So, and let me say, lengths you need a for the streamlined resheathable. Mentioned.
Oh, no. Yes. No, no. Is he at the next? No.
And we shuffle and okay. So let's see some and this is only parenteral diversion technique out of the aneurysm sac. They started with grafting definition. Okay, we can do that. Ah, okay. This one, is it? Okay. Let's continue. The stent grafts. Then it continued, which was versus came modification from as those have certainly created and this, we have making for numbers the basic selected cases with dedicated pipeline. We don't like pleasure and high back, still do not, and if we don't have to do it. And we still use pleasure aneurysms if it's feasible, modification. So without the change geometry and without, when you place at the neck of the aneurysm, low actually. What the aneurysm is basic. So this is actually to have those with the large C to be treated with telescopic stent price and neurologically in the flow should. So this is not a, there is an aneurysm we don't even treat, and if you look and the 9 is cured. Yeah, the aneurysm in this particular stent dissecting pike aneurysm without too much Besch density, keeping you. If this is not placing flow, is the 48 our flow line. We have a very limited experience with Fred 2 that we actually we have the flange large infarct. So we've been still supported very showing that. So we have a was done with pike and which is very was done with the Hasler. Our team members can give you the same without too much mesh because the telescope is small aneurysm modeling effect of the we have basically of the aneurysm artery. Choice is called telescope distal basilar. Result rate is much higher treatment because the large aneurysms here disease. This is atherosclerosis hole in the periphery. So this is an animal. You have a perfect one because his change actually cannot treat the techniques and niche and described is called basilar type aneurysms. This is done with double enterocostal cell stent. Is those stents create which was very studies. So basically this and this is just treatment. You see the shrinkage of aneurysm causes basilar bifurcation. The most effective. So this was another and maybe sometimes having the right the obstruction diversion because of flow demand. So the main thing, the biggest problem actually in the large angina was that inflammation effect. In one patient, those basically the from and this and at the base we can and some happen. We have case intensive patient and most fallen and the patient lower cranium 2-3 months the 1-year control. Imagine if this was to go out of very effective anti to control converters. I'll be control speeder flow in this giant solution or particular patients that are experiencing us that this is going to have the clot rupture. Wait for 100% flow diverter. So this first treat with telescopic stenting and high reconstruction. You can control. So it was a great revolution for the blister line aneurysms coming off the sac. Vessel important, which was the main for while is for a certain period of time. It gives you a good process. It's strong remodeling either one of. So we like in this. I see a term. I was just thinking the progressive deconstructive element of this criticality of that with this sac may end up with stable remnant as we see 1.5 year MR angio from this pipeline treatment. The revolutionary aspect of flow BLX cases except for me that it's just vessel intact and this change actually treat rhythms and or making MCA bar and these are all happening because of the occlusion of the critical starts to fill cases all of the aneurysm at the time very narrow area here and this is the control the suck of the MC. We need a nuclear interval change from one from the another. This is the but in a 1.5 year hypoplasia of the was like wanted to put VB intervention. Unfortunately, the has been very, without the light transmission aggregation. Without the patient, okay, then do the pre-rate rescheduling rate in the Y stand more than every 4 patients being rescheduled, showing that is not since we fluctuated in the night response, and then the patient had a. We suggest you to produce 5 to 10 milligram maintenance and response or continuous cerebral bleeding. You can place in aims. Of course, this was very these patients from experience in the bifurcation. How developed 2%. Last flow, we're all exact consecutive angiographies. There's another called by the time. Those remnants, this is our resection, and just if you very selected cases, complex aneurysms, this take building, so much quicker and building effect, you resulting in the aneurysm happening much faster in. And this is a very great, just 3 months aneurysm sac show superior trunk as the control flowed resuming the continuity the 18th medical they need them without agent intrasaccular device that there will be no coil. Circular flow modification, their patient. So having endovascular, very recent CA bifurcation, but go there, play flow modifier, and basically bystand technical detail. I love it. I'm not sure if you're going to
Hesitation, no? Fast, eh?
And I one of the most interesting reason why I feel that problem, as you have seen today, we can issue with an aneurysm involving developing that more like you see here is involving a significant in fact, the mid third, a little bit of the disease we're going to talk to the problem with my toys, you're going to take, I will do this problem that we use the same, we use all few things we learn over, then is natural history of the basilar formisms long term. For me is that eating, and the reason I will pose to you, and this is very controversial, is I have a heart baseline, or this patient is a, or you're not controversial here is dangerous to this, to be less effective, but eyes from the disease as soon as it gets diagnosed. For me, it started, we use a magic device, and this aneurysm had an we had to work on, we could never get good access with the endovascular, was not learning a lot from this, using this. This is very wide of therapies on without, say, only overlap. Full construct, metal to not, for example, in the first, if you would stick to is asymptomatic. For me, initial publication, but they with reanalysis of the posterior circulation, 13.2%, different disease bag of posterior. So this publication, what we want to protect the perforating basilar, or if not, morbidity, the basilar will rate lower portion coverage. You don't want the cause symptoms. So one approach would be to tolerate. Or you can say, I'm going because you want a slow thrombosis back, and then not an early stage. You, I think this is highly debatable to learn, but you is a case that we below diverter than above ICA. We try to place, and you realize what you so the basilar has with flow diverter there, you will not inside of this would work. You have interlapping of a having to deal with a mismatch and decreasing in the lower back local months, and is that this patient more closely was not, he got worse than back to occlude the, so we did the enter because the patient you can this is with, I'll tell you how much it look like. We help under this, patch this and treat the stage, but this patient now follow up, and in tailoring that treatment, some is more prone to treat, and this is how we're only % coverage. Alluded to that, you can increase that, and that's probably the how we look now, how this disease top of the base. This is just showing the clot sac is moving forward. A case that has in the action in with this stage to build seconds. They don't want to go with the pipeline to anchor position fitting between the two ends. What is to allow that to the aneurysm is to stay pipeline back that had enterprise. You see here the see this vertebral this construct now vertebral coverage. That's one have today that there may be different coverage or multiple. I think we'll learn more coverage. So in you can see this is a popular art to have. this topic, first of all, basilar fusiform to state and proposal of a variable or a better treatment fits all. If you have that aneurysm based on that, is a very actually how to control perforator inside of the aneurysm slowly to be staged. Intravascular that's in the future. I'm going to move on to another topic.
Dr.
And than anyone, persuaded to wait until the patients become symptomatic. When I lacking the margin patient, and in reality, you're not doing differently in every. You're just go quite. You thinking that your history growing until you finally get the artery. It's time to get something. One side, I'm not. It's a worry that I kind of advance. Many of these are young.
I mean, I think to know which rate that we have one treatment treat with this somehow. It's us. I think I want to know that the outtake that many or top of the fingers that things are. I think that I don't or a neuroform in the top of the bas. Though we didn't know what was speaking today is not what I feel more like this. I'm very pleased how they're not headaches. Diplopia, something's happening. The patients that we never they flow divert gets symptomatic, and but time will be at this.
I guess what I'm symptomatic, so we don't still having to experiment treating a minimally symptomatic patient.
If you means that your of walking, these are the two things. Let's say the at that time when it gets to that, you can.
See. I think patients form basilar aneurysm through the ICA segment. How the patients say to people, quadriparetic and then for whatever reason, yes, but I've been I know came with end-to-end all over the place.
No.
And so trick is that the patient does things in them. They for a little while because the sun come back to you and you.
And it's possible there a cure be that, but even the patient comes in to place someone aspirin for the disease is that you describe microstrokes long time for the time they become that's what I'm the disease because luckily progressing.
I'm just experimentify the
there is with I don't think that there is one.
I would agree, like you of devices each.
There's one thing like that the statement
No.
because that cures themselves.
So recognize that we know how, and then we. But I think that with this kind of a lion at you, and I'm not saying because for a while, and they all aged therapies unless it's staged over in.
And this is part just that place. I'm trying that.
No, I'm watching what those are going to be. Afraid when we can fool yourself by a stage.
I understand.
So
I think that is a very long. You do a stage 3. The day you close, consider the front, upper head. These people that it's really trying to just kind of catch up again. Smarter to do.
The other is that, close, but their time to reach you close.
After that, if they become sensitive, you would want it to. But I think you take a two. I think that's a big problem.
Coming from, I'm not. Has anybody the of these
article a year natural history I don't know what it is, of an annualized rupture risk. From other causes.
Specified, meaning
Well, that's-
vascular.
The beginning of different cohorts, and some cases like the one now, this is amazing. It's a drug.
If you, of the disease interrupted, and it's in the arteries, so it's risk.
The point of this, I think, is because there's what we don't malignant versus one issue. We don't have enough weight, maybe even that triggers things that we don't is not only look at the head, but look at the body. Even there things are kind of approach is every day you come in, start doing a particular problem, you start consistently that approach. Now this, it's very difficult to learn much. So places this approach, we'll see where that it may be that all recurrences, so. So the events is probably, but mass effect is we're talking about here. It's not gonna.
That's the question. A stroke, I can tell you that maximally.
Old. I mean, this problem.
Yeah.
But the point,
this be known, and so.
We're probably a big mistake. We used to see these people that may be they will die of a heart.
I find all have a cardiologist. They're on patients to these, usually fairly intensively. Look, there's a psychology to the fear and the I guess we'll see what in your next.
Thank you.